As you know, my name is Dr. James Zhang. I'm a GP by trade, but I'm also the clinical lead of the NSLHD long COVID unit. And to give you a bit of a background about me, at the end of the day, I am a GP. I used to work in St. Vincent's Hospital in their COVID unit, the acute COVID unit in the time of the pandemic. And I got to see what they were doing in the long COVID unit as well. With their permission, I've sat in on their MDTs and realized a lot of what they were doing for long COVID is really great and really thorough, but not dissimilar to what we can already do as GPs with utilizing allied health. And so my role in the NSLHD has been creating a long COVID unit that's been a lot more allied health focused, but also purely virtual. Because we also know that there is a bit of an access issue, and we know that for people that may have referred to St. Vincent's, there is a 12-month waiting list and or going to private telehealth companies for long COVID. They could be a 4 to 6 month waiting list, $400 for a 1 hour appointment. So I'm really excited to share with you a bit of my learnings about just long COVID in general, what our unit does. Hopefully it's a little bit of preaching to the converted, but also then telling you what our unit does as in NSLHD and how we're now collaborating with the Central Coast unit. So definitions, just to start with, long COVID is 3 months from the COVID illness with symptoms lasting for more than 2 months. And it's a diagnosis of exclusion. So really ruling out other conditions first, and usually just doing a set of screening blood tests, lethargy screen to make sure we're not missing anything major like cardiorespiratory issues or iron deficiency or cancer screening as we do. And it has a lot of features. It's so varied. You can get fatigue, shortness of breath, brain fog, as people call it. Other people may have really, really bad gut dysfunction. Other people may have ongoing issues with mood. It's very, very varied, and it can just persist from the initial illness or come on after that initial recovery. But it's very, very up and down. The long COVID landscape, as I see it, is, as GPs, I look at all of these different conditions and go, each and every one of them, I think we're very comfortable and capable of managing. Cardiovascular disease, DVTs, OSA, asthma, joint pain, diabetes, IBS, depression, anxiety, fatigue, headache, migraines. That's all relatively within our bread and butter. But the moment you call it long COVID, everyone loses their minds. And so it's very much how do we break everything down symptom by symptom, system by system, and support the patients in that way. The larger landscape is the ACI have come up with a 3-stage model of long COVID management, where the majority of cases do get better with a bit of self-management and a little bit of help from their GP. 80-90% they find is roughly the numbers. But having a stage 2, stage 3 level of care, where stage 2 is emerging models of having, say, community nurses help navigate outpatient systems or investigations, and stage 3 where you have a specialized multidisciplinary care team, that's a lot of where the landscape is currently. And even then, it's still very emerging at this point. Our unit kind of sits as a bit of stage 2 and stage 3, with the CNC at the CCLHD that we're collaborating with, focusing a bit more on the stage 2 part, and we're guiding her on that. The key statistics that I tell people is long COVID is very much a real thing. It affects about 1 in 20 people post 12 weeks. And just because the incidence is relatively high doesn't necessarily mean it's severe, however. For case in point, I would say I had long COVID. I lost my sense of smell for about 6 months, for lasting about 6 months after COVID. So by definition, that would be considered long COVID. And at its peak, I could suck on a lemon and it just won't register. Did that affect me? Arguably more of a nuisance than a concern, but by definition, it's still something that would be in that number. But obviously, it can be so debilitating for many others. And the general correlation is the more severe your illness, the more likely you may get a post-COVID syndrome. And we find that the milder strains, there's less of an incidence as a result. There is a lot of hope that I tell patients, and based on the BMJ study where they followed up about 1 million people that were vaccinated and no other major comorbidities, they found that 85% of patients who had long COVID would resolve to baseline or near baseline at the 12-month mark. Median duration is about 4 months in the community and 9 months if you're in the hospital. But I tell people, look, odds are generally favorable that you will get better. This is really just to remind us that even with acute COVID, it affects so many different systems. So if it can affect so many systems in the initial acute illness, by logic, I feel like you can get a lingering phase of illness with so many other things post-COVID. And I'm not going to go into the nature of all of this. I will also distribute all these slides afterwards tonight as well. So it's open distribution and open resource. I'm a firm believer of that. Why does long COVID happen? It's still very much a We don't know. I wish we had just this one blood test or one investigation to work it out, but there are so many different theories out there. There's possible immune dysregulation, where there could be a persistent viral illness that may not necessarily be detected, but could still cause ongoing illness or ongoing inflammation with the immune system being primed. It could have reactivation of other viruses like EBV. Gut microflora, gut microdysbiosis, it's a thing even out of COVID. And with people who have nausea, vomiting, diarrhea in their acute illness, sometimes that can be a lingering thing afterwards as well. A lot of blood clotting abnormalities. I've seen patients come in with PEs or very, very tiny PEs with no other prior conditions presenting, and they have a positive D dimer, and you do a CTPA and it shows up. And there's also a lot of autonomic dysfunction as well. We've seen a lot of patients with POTS, postural orthostatic tachycardia syndrome, and I think that's been a lot more prevalent on our radar ever since COVID. But from our point of view as a GP, a lot of it is screening to make sure we're not missing something like a pulmonary fibrosis or a myocarditis with ECGs and simple blood tests, pulmonary thromboemboli for people who may have dyspnea or risk factors, the usual things to do with cardiovascular screening and disease, diabetes, dyslipidemia, doing lethargy screens. I think that's all very much within our bread and butter, but one of the other things that a lot more of us could be doing in screening is how has that actually been affecting their mental well-being, and how's it affected their ADLs and employment, because so many people need that additional support, especially with allied health, especially with return to work, that I find that often when it comes to long COVID, this category probably has one of the biggest impacts once you've ruled out the above categories. The way I explain it to patients is, look, in this day and age with iPhones, battery is a very easy analogy. Your body is a battery. Even prior to COVID, you do any sort of work and it naturally goes down. We've all been there. You've done an all-nighter. You've had a very, very long shift. And if you're drawing from an empty battery, it can manifest as all sorts of things. I get drained, wheezy, breathless. My head hurts. I get palpitations. My head is throbbing. And this is prior to COVID. And I'll argue, is there anything wrong with your heart and lung when you're trying to draw from an empty battery? No, but your heart and lungs and brain are trying to draw from an empty battery, which is why it manifests as all sorts of different symptoms. A lot of things may be happening in COVID. Maybe your battery is compromised, so the heart and lung are affected, so the battery is now cut in half. I find that the majority of patients don't fall in this category unless they have pre-existing heart and lung issues already. So they already have previous ischemic heart disease, they have previous COPD or asthma, then I definitely want to hone in on that a bit more. But for the young and generally well and healthy prior, usually I find it's not the case, but my duty is to make sure and screen that we're not missing that. I find usually it's more scenario 2 or 3 or a bit of both, where the battery is okay, but maybe your charger is affected. And the only way you can recharge your body is eating well, sleeping well. And if you're not sleeping well, then of course you're not going to charge your battery up to 100%. It only goes up to 50% and you start the day kneecapped. If you're not eating well, of course that's not going to help with your recovery process. And part of that as a GP is I'll screen for sleep apnea as well, because sometimes that can manifest post-COVID. Now, scenario 3 is often where I find the majority of patients where the battery is okay, but the energy demand is higher, whether it's because they're still really trying to push through with their current ADLs in this recovery phase. Maybe there are inflammatory processes or other things that I cannot identify on a blood test because research is so early. But I know that the common story is I did work, I pushed myself a lot harder, and I've crashed the next day or two afterwards. And it's how do I manage your battery so that once upon a time, a bit of housework would go from 100% down to 80%, but now it's 100% down to 20% battery. So it's really about how do I help manage your battery, your ADLs, your work to try and maximize your function and not blow that battery to bits. And going back to that 85% recovery from the BMJ, I tell people, look, if I look at you today and I look at you 6 months from now, I have every reason to think that this is going to be the data points. We as doctors will only see patients on a data point. However, you have to live it out every day. So often people have this expectation that, you know, where we are today to where we are 6 months from now is just going to be this linear, I'm just going to get better day by day. But we all know that the reality is you have to live it out every single day. So it looks a lot more chaotic. And what we don't want it to be is this downward spiral where you get energy, you crash, you get a little bit more energy and you overdo it and you crash and you end up just in this vicious circle of getting worse. Because often that's what we see in these long COVID patients when they don't actually pace themselves and get the help they require. So often I tell them, look, the whole role of what my team does is how do we actually optimize where you are currently at and make a plan that is more tailored. And I know, again, as GPs, we always talk about the biopsychosocial model of care, and we talk it to death as it is on the textbook. But often I find that, especially with specialist units or specialists, it becomes so much on the biological and neglect everything else. And again, there is a place for focus on the biological to make sure we're not missing any chronic diseases or other illness processes. But very much I feel like it's focusing on biological at the expense of psychological and social, which is often where it's the bigger impact. I tell people, look, there's no magic bullet solution to long COVID management. It's all about working out where the patient's issues are and unthreading all of those things little by little, bit by bit. And a lot of it is very much about that validation and symptom support, knowing that they're not alone. There is a reason why it's called a therapeutic relationship, because even the fact that we as clinicians link with the patient to journey with them is therapeutic in and of itself. Often it's so disempowering for patients when everyone around them is going, well, I had COVID and I got better after a few weeks, so why aren't you getting better? And it's an invisible illness that's so disempowering. So setting up support structures and journeying is so very important. And the ACI is also very validating of this. It's very much chronic disease screening and making an individualized rehab program. And it's very much allied health heavy lifting, not the specialists. So a bit about our
James,
service.
James,
Yep.
perfect timing. I was just going to let you know, in terms of a time management side of
Yep.
things, we've got about 10 minutes more left. So
Yes.
feel free to,
I'm going
we're
to
very
speed
excited
through.
to hear about your service and how we can refer to you guys.
Absolutely.
That's really
So
key.
our service started in May last year. We're 1 day a week for all the different clinicians. When we have a CNC who's the backbone who works 5 days a week, it's 100% pure virtual, and there's a reason for it, including group sessions. And that's because, let's be fair, access to health is difficult enough as it is. Why would I want to send a patient to go to some clinic in the city? They spend 2 hours to travel there, and by the time they get there, they're already wiped out. Just to be getting a 1 hour assessment to be told things which thorough, yes, and very holistic, yes, but it will just be very much advice that can be done virtually just as much. And we find that if we really needed to review in person, there may be a place for that, but often that's more, I need to send you for investigations. And again, we facilitate that to the local districts. But we have myself as the clinical lead GP, and I have immunology, cardiology, neuro, and respiratory on demand if I need to. I actually found that I haven't needed to refer many patients to them at all, because often if the screening process has been done well, often they don't need that much involvement. We have a full suite of allied health, with the exception of a dietitian. So EP, physio, OT, psych, social worker, speech path, we have a lot of people. We have reviewed and accepted 84 patients to date, and it's been a very steady stream. And one of the biggest boasting points that I have is the time that we accept the patient to when we do a first review is less than 2 weeks, and that is still the case today. The only reason why it isn't any lower is because patients don't pick up their darn phone when we call them. But that's one of those things where that's why we want to now collaborate with the CCLHD, because we think it's a very, very helpful program, not just for our NSLHD, but to also cross that with areas that could really access that care. We also have a COVID advice line. It's on the slides. You can have a look at that, but it's just a number that you can call if you need a bit of advice on what do I do. So our goal, very much empowering patients, managing common symptoms, and if we get the vibe that you need longer term supports, because we're more a virtual short term, medium term, 3 to 6 month service to really empower GP and patients. If we think you need something longer, we'll make that call and facilitate as well. Applications for things like the DSP, very rare instances, but we have done a few, or ongoing paperwork to advocate the GP, we do that as well. Allied health, you can have a look at that in your own time, but this is just some of the things that our allied health do. Our specialists really only get involved if there's any abnormal investigation findings or if we need their help to get specialist investigations. But I've already made the links within CCLHD on where are my options to send people for spirometry, respiratory investigations, for TTEs, for MRIs. So if patients get referred to the CCLHD, we'll help facilitate that. And of course, if there are any major symptoms and issues going on, our specialists will review patients virtually as well. Now, the exciting thing is the CCLHD. So we've launched this as of last month. Lorna Hatcher, who's the respiratory community CNC, is an absolute gem of a person. All referrals we will currently do is through email, because HealthLink, I wish we could get that up and running, maybe one day soon enough. But at this point in time, all referrals will go via email. access to investigations and referrals, we will handle it once you get the referrals through to that email, and Lorna will help process them. All I simply require is making sure that the patient is in the CCLHD, making sure they do have long COVID. So it's been 3 months since their COVID. And before I accept the referral, and I think this should be a fairly reasonable workup for the GP, is you've done a chest x-ray and these list of bloods. And I don't think it's unreasonable, because I look at that list and it's it's the same as what St. Vincent's ask, a little bit less. I don't ask for zinc and selenium, but it's very much a lethargy screen. You may look at this and go, why D-dimer? That is because of the theory of microclots with PEs. So if your patient does have dyspnea, I do ask for that, but if they don't, that is fine. But as long as you've got all those bloods, if everything has been done, we accept the patient and they'll be seen within 2 weeks. And they'll be either seen by myself or the CNC, whether it's my CNC and NSLHD or the CCLHD. And then we'll get them through into our allied health and review from there. So to summarize all of that, long COVID, it's an invisible war. Multiple conditions to screen and rule out, but it's a real thing, and there is a lot of hope for patients. Majority of people do get better over time, but the biggest evidence is get out the major causes and provide pacing rehab support that works for the patient. And allied health, especially when the community, it can be really expensive and hard to get, especially when it's not necessarily a unified team that all speak the same language on pacing and COVID and holistic management. It's very different. And we all know that getting an OT report can cost several hundred, maybe $1,000 even, especially if we're going for application. So the fact that we're doing all this in-house means we're hopefully providing better access to patients and better care for people all around. The key contact is Lorna Hatcher, and her email for referrals is that email there. And I've also created resources for GPs on how to assess patients for long COVID. And again, this is not necessarily something you have to do, because again, I'm a GP. I get the benefit in this clinic of reviewing patients for an hour, which I know as GPs in clinic we don't get as 15 minutes. But even if you pack it into a 30-minute appointment with a template that I have created, I think it's at least a start. And you can always use that same template to be the foundation for your GP MPs, which at least you get a bit of money and effort and reimbursement for your efforts as well. But essentially, the summary I wanted to give is NSLHD long COVID, we're open for business, and I'm very, very keen to collaborate because I think we've been really, really excited about how virtual care and doing it virtually 100% really helps open the doorways to getting people at the care that they need without having to go from appointment to appointment, from clinic to clinic, and wiping themselves out in the process. And the fact that we use e-referrals and everything is virtual means I don't have to worry about clinic space. And I think it's probably one of the biggest reasons why we can see patients so efficiently as well. So I'll send out all the resources on our workflow, how to refer patients, as well as these slides. And I'm more than happy that if you guys want to reach out, feel free to let me know as well. But that's the big spiel that I've got on my end. I don't suppose there's any burning questions in amidst all of that.